Excellent. Good evening, everyone. My name is Annie Benzie. I am the chair of the fellow subcommittee for complex GI surgery fellowships for SSAT. And welcome to the official last grand rounds of this academic year. We're very excited that you are all here. We have a great talk, kind of continuing our foregut series. Just a kind of a brief reminder for our fellows as well. As it is the end of the year, the fellowship certificate is now open. You all received an email late last week with details on how to apply for that. If you have any questions, concerns, please just let Beverly or myself know. We really encourage all of you to apply for it. It's definitely going to be helpful as well with your credentialing when it comes to your real jobs, quote unquote. And again, if anyone needs any help with anything, their certificate, job hunting, the faculty on this call is more than willing to sponsor you with any assistance that you need for that. So please don't hesitate to reach out to us. So without further ado, I'm very excited that Dr. Karen Gibbs was able to join us. I've been tracking her down the last 3 years to help us out with moderating with this, and we are so delighted to have her. She is the Surgeon-in-Chief and Chair of the Department of Surgery at Yale New Haven Health Hospital, and she is going to introduce our fellow this evening. Dr. Gibbs, the floor is yours.
Thank you, Annie. This evening we have an excellent talk, hiatal hernias and bariatric surgery, and that comes with a lot of controversy. So we're hoping for a lot of engagement today. We are happy to have Dr. Ryan Soham, who's finishing up his fellowship and ready to move on to Michigan for his real job. And so if you have any questions, please feel free to put them in the chat. In addition, if you'd like to raise your hand and speak, we're happy to engage. We'd like it to be as engaging and interactive as possible. So thank you and welcome. And Dr. Soham, I'm going to turn it over to you.
Perfect. Thank you. Thank you for the introduction, and thanks everyone for coming. I'm Ryan Soham. I'm the fellow at Banner Gateway Medical Center in Phoenix, Arizona. The topic today is hiatal hernias in bariatric surgery. I probably should have titled it hiatal hernias and GERD in bariatric surgery to be more accurate. No disclosures. Some outline for what we're going to talk about is briefly the background of the disease, the preoperative evaluation of these patients for bariatric surgery, intraoperative evaluation, pearls of the intraoperative repair outcomes, recurrence, and then if there's time for case examples at the end. So obviously hiatal hernias and GERD are of key importance in bariatric surgery, as all of these surgeries are reflexogenic and can make issues worse. In terms of incidence and prevalence, the ranges are pretty varied based on whatever epidemiologic study you find, but in the general population, it's estimated about 20 to 30% suffer from reflux, and in the obese population, it's higher at 35 to 70%. Similarly, for hiatal hernias, incidence and prevalence of 5 to 20% in the general population, and somewhere between 20 and 60% in the obese population. So this is important to us, especially in bariatric surgery, because it matters in terms of what surgery we offer to a specific patient and how we're going to manage and treat either medically or surgically reflux and hiatal hernias preoperatively or postoperatively. Some risk factors that we're all aware of for hiatal hernias and also for reflux of increasing age, increasing BMI, conditions that cause elevation of intra-abdominal pressure, chronic straining, COPD, pregnancy. Regardless of what classification system we use, but the two primary ones are the Hill classification, which looks at the relationship of the GE flap valve and the hiatus, and more recently the American Foregut Society grade, the AFS hiatus grade, which takes those same factors into account, but also includes the hiatal length, aperture diameter of the hiatus, and the presence or absence of a flap valve to give a different scoring system. But regardless of the scoring system that we use, the reason that this is important to identify is because we want to know if there is some sort of pathology or condition that's going to change our management. And so when looking specifically at bariatric surgery, there are two primary ways that the preoperative evaluation for these are done. And it really depends on the institution and the surgeon, with the primary studies being preoperative upper endoscopy or an upper GI fluoroscopy. For endoscopy, we would identify things like a hiatal hernia, esophagitis, gastritis, presence of ulcers, or less commonly, surprise masses. And fluoroscopy can give similar but different information about hiatal hernias, anatomic abnormalities, or motility issues. So talking about specifically to start endoscopy, the question is, do we need to do it and who does it? So there's varied practice nationwide and surgeon dependent of some will screen everybody preoperatively, some will screen only those who are symptomatic, and some will use a different study altogether. There's also questions of whether or not insurance requires or even insurance will cover it. So there's lots of factors that go into the decision making of when it's done. But looking at this 2016 meta-analysis published in Obesity Surgery, which was the largest study looking at this topic, it examined 28 studies with 6,600 patients who underwent preoperative endoscopy. The findings there were that 92.4% of the patients had negative findings, or findings that would not significantly alter the management or plan for surgery or medical treatment for those patients. But that did mean that 7.6% of those patients did have findings that either delayed, canceled, or altered the surgery. Things like a large hiatal hernia, grade C or D esophagitis, a stricture, or malignancy. And the rates of those were listed here. Were findings of gastritis of 35%, hiatal hernia at 20%, esophagitis at 18%, Barrett's at 0.1%, and malignancy at 0.08%. And then looking at the two major groups of ASMBS and IFSO for position statements on endoscopy, I'll read them both here. The top one with ASMBS. While some of these findings do not modify medical or surgical management, routine pre-op EGD is justifiable and should be done at the surgeon's discretion. And if so, is similar, but maybe a little bit more towards EGD, where it should be considered for all patients with upper GI symptoms planning to undergo bariatric surgery, or EGD should be considered for patients without upper GI symptoms who are planning to undergo a bariatric procedure due to the 25.3 chance of an unexpected finding that may alter management or contraindicate surgery. So it's not necessarily required, but there is a lot of good reason to do it. Looking at upper GI fluoroscopy, which is done for routinely in some places or in specific patients and others, but the practice is just as varied with endoscopy, although there's not as much published about specific findings and rates and even position statements regarding it. But it is known that it is less sensitive than EGD, especially at detecting smaller hernias. And the other thing too is that when we see the contrast refluxing, or we read the report that there's reflexive contrast, that doesn't necessarily correlate well with actual pH testing. So whether or not that's clinically useful is another question. There was one good paper published in the Journal of GI Surgery in 2020, which was a retrospective review of 209 patients that were undergoing bariatric surgery who had both an EGD and a barium swallow. And it looked at the sensitivity of those tests with a hiatal hernia, identified only 52% with EGD and 34% with barium swallow. So while both were fairly non-sensitive, EGD did outperform barium swallow. There was one comment on one of these, an editorial comment that I think may be a little too harsh, but it's knowledge gained by upper GI fluoroscopy is mostly useful for scheduling rather than for management. And I think that comes from the point that if the patient has clinical reflux, that's what matters rather than the various findings you can have. And if you see a hiatal hernia intraoperatively, you're going to fix it, and the person who wrote that may not change their management of what they offer a patient based on the presence or absence of a hiatal hernia, but something to consider. And then the kind of emerging method of preoperative testing in these patients is high resolution manometry, which is used in a lot of cases. And as we know, it helps to measure motility and evaluate the GE junction. It's done with multiple swallows in the upright and supine positions with the probe in place. This was studied in a paper published in Surgical Endoscopy in 2020. This was the largest paper and prospective study that included only 41 patients. But those 41 patients all answered the GERD quality of life questionnaire. They had a barium swallow done, they had an upper endoscopy done, and they had the manometry. And they sought to compare the sensitivity, specificity, and predicted values of the different options. And the findings were pretty consistent with what other literature showed, where high resolution manometry was the most sensitive in detection of hiatal hernia. And upper GI endoscopy was second, and then barium swallow was the worst, with similar findings here of the predicted values and specificities. There is also some emerging papers and people publishing about the use of EndoFlip and where that fits in, but there wasn't a whole lot of good data regarding that. I'm going to move on to the next part of the intraoperative evaluation, but I was going to pause here to see if anyone had any comments or wisdom regarding their preoperative evaluation.
Great time to pause. And Rohan and I are thinking about the same thing. So, high resolution manometry, that obviously here shows great sensitivity, but do all the rapid swallows make a difference? The supine versus the upright? What do you think about that?
Are you asking me?
Yes.
I guess I don't think they do. It is the most sensitive, at least at identifying a hiatal hernia, but it's also a lot more invasive and costly. So I don't think that it necessarily offers enough difference or new information to make it worthwhile preoperatively. It might help guide of what surgery you offer if there is some associated motility disorder, but I don't know how common that would even be found.
Yeah, great for achalasia, right? So Rohan.
Yeah, so I mean, we kind of come back to this radiography versus endoscopy discussion. And, some people, I know Sharona Ross is a big fan of the marshmallow bagel test and just symptom complex, right, as you're thinking about these things. And I have to tell you, Dr. Sohaim, my patients complain most about their high resolution manometry of anything that you do to them, anything at all. They hate it. So I just asked that question. The other thing is I personally love barium swallows because I have a little bit more of an idea of esophageal length and also of what they look like physiologically when they're upright as opposed to supine, because I do think that the diaphragm is a very dynamic, issue, especially with a hernia, in that when you lay them supine, things can look very different to upright. So I was just going to make that comment. And my last comment is, we're huge fans of EndoFlip, intraoperatively, specifically for these patients. So I do think that this is something that's going to be coming down the pike. I mean, a lot of people don't have it, which makes it a little bit limited. But I was just going to make that comment. And obviously, in the face of the bariatric population, your your handling of reflux is going to be so different, right, than in your typical primary refluxes. So I just wanted to make those comments, but I'd love to hear what Dr. Gibbs has to say in response to those comments.
Oh, great comments. I think I've done the full gamut where I did endoscopies on everyone, and then have transitioned as different locales have different practices. I happen to really like the upper GI, just having some control over looking at the anatomy. It gives me a lot of information, but I have to say that many radiologists no longer truly get a in-depth knowledge in terms of performing the exam and reading them. So I'm very actively engaged when I need my patients to have upper GIs. But in terms of the endoscopy, I just wanted to get some feedback in general. Are you seeing our endoscopy colleagues truly giving the types of grade in their reports? Because I seem to think that's variable.
at least from my limited experience, I think it is variable. In residency, those endoscopists would always report Hill classification on theirs, and here we perform them ourselves.
Go ahead.
Dr.
ahead.
Bentley, do you want to call in anyone?
Yeah, I was trying to get in.
Okay.
No, I was just going to say, Dr. Benzi, do you want to call in anyone in the group to ask about whether the endoscopists are providing that?
I think Dr. Pokemeni wanted to take a comment, but
Okay.
I just want to first apologize because I'm having problems connect.
got it.
We have you now. We're really thrilled to have you, Dr. Podkameni, who's the program director for this program. So thank you.
I apologize.
Just to answer your question, Karen, I too have issues. We have one endoscopist who's super interested in esophageal disease, and you get like the biggest explanation regarding the Hill grade. But for everyone else, it's sort of like, yeah, it's loose, it's floppy, yeah, kind of thing.
All right.
Excellent. Thank you for the.
I do kind of a follow-up too. I just was wondering, how important is H. pylori testing in this patient population? Because I know that was a big justification for performing our own endoscopies with biopsy on these patients. But is that something, when I was in training, but is that something that is still extremely important? And how does that change your management when you're thinking of bariatric procedures?
Yeah, so I did look into kind of the most relevant and up-to-date information on that. It is also a mixed bag, I would say. Just like there is varied practice with endoscopy, there's also varied practice with routine or non-routine testing for H. pylori, either during endoscopy or with a breath test or various things. If it is positive, this kind of consensus is to treat it and make sure you clear it prior to bariatric surgery. But whether or not that's been shown to make a difference in the outcomes, I couldn't find.
I don't think the main issue is to make a difference in the outcome. I think it's the problem is once you get the diagnosis of H. pylori and this is after surgery, it's an additional thing that you have to exclude or treat. So I think it's always advisable to do it preoperatively, just to avoid any type of confusion problems or mistakes when you're making or trying to make a diagnosis, especially on patients. Since we do most of our surgeries are sleeves on the sleeve patients, I think it's important. And also on the bypass patients, it's important. So we have no access to the remnant stomach afterwards. So you have to rely on either a blood test, breath test, or a stool test in order to make the diagnosis. So this way you lack the possibility of doing a biopsy. So I think it's always important to do that evaluation preoperatively.
Great points. Just wanted to add that Dr. Welch made a comment about GIs that I get the best responses when I ask specific questions, and that makes sense.
Yes, perfect. And so moving on to the next section, this was all about the preoperative evaluation for a hiatal hernia. And what you'll notice in all of these tests is that upper endoscopy, fluoroscopy, whatever you're doing, is always compared to our gold standard, which is intraoperative evaluation. And so that really begs the question is our intraoperative evaluation actually a gold standard of, if we see it in the OR or don't see it, does that actually correlate like appropriately with EGD? So when you're in the operating room, in all cases, we perform a routine inspection of the hiatus, looking for the presence or absence of a hiatal hernia. Sometimes it's obvious when you can drive a truck through it on the left there, and sometimes it's not as obvious on the right whether or not there's a hiatal hernia. There is no standardization in terms of how you're supposed to evaluate, how aggressive you dissect, and what is the true balance. So I thought it was kind of fun and adds to a study that I'll talk about in a minute. I have a couple of small clips of various operations evaluating the hiatus. And if you have your video on, I'll just make it easy. Thumbs up if you would repair this hiatus that you see, and thumbs down if you wouldn't. And it'll, I think, show some of the variability in terms of how they're assessed. So this is someone going to do a gastric bypass or a sleeve. Their method of testing it is by pushing on the anterior part of the hiatus. Would you repair it or not repair that? Just based on that information. I know there's limited of, we don't know their symptoms and we don't know anything else. So I saw a couple of thumbs down. I will tell you that this one was actually repaired based on that information. Here's another one where this surgeon, a different technique, they pull to see how it springs in and out. Would this get a thumbs up or a thumbs down for the crowd? I'll give the answer where this was also repaired. And then this one on the bottom, a little bit of a different strategy, and maybe I truncated these videos too much, but looking for the angle of his there and evaluating the hiatus, they also push. This one was also repaired. And then this one laparoscopically, you can see they do their push technique in a different location. And this one was not repaired. So
Just a question.
Yes.
Did any of these patients have an endoscopy or a PGI that might have biased the surgeons to do the repair?
Yep. So at least I know for these first three, they did have EGDs that had all reported Hill grades in them. The last one I couldn't tell you. If I'm remembering correctly, this was a Hill grade 1 on endoscopy, the first image. This one was a Hill grade 2, and this bottom one was a Hill grade 1. So whether or not that biases you one way or another, I'll leave that to certain, but it just goes to show that maybe, there isn't a good consensus of, how good our intraoperative evaluation is. There was one interesting consensus conference. It was specific to sleeve, but I think it was pretty generalizable, published in SWORD in 2014, done in 2014, a survey of 74 surgeons who asked different questions regarding the evaluation of the hiatus during sleeve gastrectomy. When asked, do you perform an aggressive identification of hiatal hernia is appropriate? They don't define what aggressive means, but 72% agreed with that. A hernia should always be repaired if found. 84% agreed, which I thought was interesting. There's not a whole lot of background context to the way these questions were asked. It was like a Delphi conference, but and then things that people would consider contraindications to sleeve. 31% suggested Barrett's, 53% GERD, and 54% hiatal hernia. So there is a lot of inter-surgeon variability in terms of how they will or won't approach hiatal hernias and GERD in conjunction with bariatric surgery.
I think that's a great point in terms of using our visualization intraoperatively as the standard. But as you can see, we think very differently, as many people who are, at least most who responded today, would not have fixed those hiatal hernias. And I would say in 2016, showing our age, we were more aggressive. I believe people were very much more likely to go after the smallest hiatal hernia. I'm not sure if we're seeing a change over time, because if the patient's asymptomatic and you have that small hiatal hernia, and we are aggressive, we are destroying some of the anatomy going after that. And then I have a sense that once you start dissecting in that area, you're going to see a hiatal hernia and you're going to fix it.
Can I add something, Dr. Gibbs? I think you are right into the point, especially on the fact that back then when Rosenthal and Gagne were part of that consensus conference, we were way more aggressive in terms of addressing that type of problem, especially with the experience that we had before decades ago with the bands. And we see that there is a good correlation between fixing those hernias and also evaluating them endoscopically and clinically if they are symptomatic or asymptomatic. I think that's an important point that we always talk about during rounds and during our talks between us and the fellow. And to prove my point is being unbiased to my own fellow is the fact that I said I wouldn't fix it. because he asked only if based on that visual. He didn't said based on clinical symptoms and findings endoscopically. And I think that correlation is exactly what we're looking for. And you're going to be looking forward for next year for the project that the new fellow is going to start, which is exactly on that line.
Outstanding.
And
Can,
then,
can I just ask
Dr.
a question,
Benzi?
Karen?
Dr. Jayaraja, I'm just
Yeah,
go
so
ahead.
can I just ask a question? Because, we're a sleeve city here in Dallas, and what I see so frequently is this cauliflower issue, where if you don't know where the angle is, you end up leaving something up in the chest or in the abdomen, and then it acts as a pressure valve, right? And it just becomes this big cauliflower. And I just see this so often because I was under the understanding that for a sleeve, you really had to hug things as you got up tight there. I know it increases your leak rate, but don't you want to stay close up top? I don't do sleeves,
You
but
want to stay close, yes. But a lot of times what we see is a sliding hiatal hernia that it's not really interfering with you dissecting the angle of his. And it's more, I think, what we normally see when we're dissecting freely the angle of his, and then subsequently afterwards you find that hiatal hernia is actually symptomatic. And there is an association of things. The fact that also that patient will end up having such a disruption at the angle of his, at the hiatus, at the cushionings of the phrenoesophageal membrane. I think disrupting the entire thing will end up causing a symptomatic or an increase in symptoms for those patients. I don't know if it makes sense what I said.
no, it does. It's just with me seeing just those patients that end up with issues, I'm so like, oh my gosh, like really make sure you're not leaving fundus there.
Mm-hmm. Absolutely. Yeah, that's a must, is to be really good about not leaving fundus behind.
Yeah, absolutely. But I do think that we've seen the transition where if people see a small dimple, they don't necessarily go after it the way it was previously.
perfect. Thanks for all the comments on that. The next slide actually talks about specifically further on the question of the surgeon variability, which was published out of Michigan. It's in the eye of the beholder, surgeon variation in intraoperative perceptions of hiatal hernia and reflux during sleeve. I thought this, if anything, was a fun study. It was published in 2021 in Surgical Endoscopy. They took 38 surgeons and showed them 33 videos of sleeve gastrectomies where no hiatal hernia was repaired. They didn't have information about the patient's preoperative EGD or symptoms. They just showed the video and they were asked, would you repair that a hiatal hernia? And they didn't know what the outcome was. 10 surgeons, so a quarter of them, 26%, identified at least one hiatal hernia that they would fix. Amongst those surgeons, there was no difference between their experience. But what was found was that the surgeons who identified a hiatal hernia that they would fix also had higher personal rates of hernia repair in their own practice. So, there is everybody's own bias of how aggressive or not aggressive to be. So, again, whether or not this is a true gold standard to compare the other tests to. Moving on from intraoperative evaluation, looking at tenets of intraoperative repair, which don't necessarily vary from when you're doing it in conjunction with the bariatric surgery to standalone, reducing the herniated contents, performing an adequate mediastinal dissection, removal of the hernia sac and fat pad, preserving the vagus nerves, mobilizing an adequate amount of intra-abdominal esophagus and crural closure. The one point that I will go into is how we do the crural closure, because that is where surgeons, again, differ in terms of how they do it. Looking at a survey also published in 2022 in the Journal of Surgical Endoscopy, they asked a group of surgeons their reported outcome, the way they repair the hiatus, and they were given options to select from of anterior repair, posterior repair, or posterior repair with biologic mesh. They also compared it with those patients' GERD questionnaires to see how this correlates. 85% of surgeons perform a posterior repair, meaning just a primary suture repair of the crus. 9% perform posterior repair with mesh. 5% perform anterior repair. And looking at results, the group of the posterior repair had the lowest mean heartburn severity score at 1 year post-op. The posterior repair group with mesh had the highest preoperative heartburn score. The anterior repair group were the least likely to have a pre-op GERD diagnosis, and they were also the most likely to have worsening GERD symptoms at 1 year post-op. So again, this is just a survey to assess, the practice patterns of surgeons, but this same group followed up to look at outcomes of the type of repair in terms of resolution of reflux and complications. So it was a retrospective analysis between 2015 and 2019 of the Michigan Bariatric Surgery Collaborative data published in SORD in 2022. It looked at almost 12,000 patients who were undergoing specifically sleeve gastrectomy, and there was overall 4,000, or about 34% rate of hiatal hernia repair in that cohort. When they looked at, they had the same type of questions about how they, how the, not questions, but analysis of how they were repaired. These results overall did surprise me that in terms of improvement in GERD symptoms, 28.8% of patients who underwent sleeve without a hiatal hernia repair had improvement in their symptoms. 30.8% who underwent sleeve with an anterior repair had improvement in their GERD symptoms, and 39.7% undergoing sleeve with a posterior repair had improvement in their reflux symptoms. I would say surprised by these because these were all overall lower than I would have expected. Regardless, but the trend I think is consistent that the posterior repair did offer the highest improvement. Looking at other things too, in terms of rates of PPI discontinuation, which is this last group bar graph here, all the groups, the no repair, the hiatal anterior repair, and the posterior repair had between 60 to 65% discontinuation of PPI at 1 year, which was not statistically different between those groups. The anterior repair group was noted to have more complications in general in terms of about 1.5 times relative risk of hemorrhage, and similar with readmission rate. The conclusion from this group was that given the lack of significant improvement and more complications, that anterior repair should be avoided. I will pause there again for any discussion before moving on to the next part of postoperative reflux and hiatal hernias.
Thank you, Dr. Sohim. Very interesting. How many did an anterior repair solely? I occasionally will, touch up an anterior, but it's always with a posterior. Very interesting to see those who would only do an anterior approach. Any comments on that?
I think Dr. Jayaraja feels very strongly about this as well, but I think as someone that does not do sleeves and does very large hiatal hernia repairs that are recurrent, I hate to break it to you, but a lot of those are because there's some interior stitches that pull through. So in my personal opinion, I would like to ban that procedure, but I don't want to speak for everyone on this call.
Very passionate about it.
Me too, Karen. I feel like you should be always able to close posteriorly if you do enough of
Absolutely.
a transhiatal mobilization. I personally believe if you can do enough of a transhiatal mobilization, you can close posteriorly. That's my own opinion, and I just feel like anatomically, that's where it needs to be closed. Now, granted that this is a different topic, but paras or hiatal hernia recurrences tend to happen on that left lateral or anterior side, but
Yes.
it's still the posterior defect that leads to that. It's not an anterior defect. So to me, I hate the anterior stitch because it's just to me it's a cop out.
Thank you. No bias here.
Well, since there is no bias, no, I'm kidding. We don't do anterior repairs. We think that anatomically speaking, the correct procedure is a posterior repair. and we always reiterate that to our fellows, is the fact that going anteriorly and trying to put some sutures is not going to actually approximate the cruise, and it's probably not going to contribute to any functional improvement that you're going to see. So I don't think it's a belief. I think it's based on anatomy and based on how historically it's being done in order to achieve good repair in terms of a hiatal hernia.
I agree with that. Any other comments? Got a healthy group here.
The next section is
Before we go there, can you go back? Two things I wanted to point out. One, just want to appreciate and encourage all of us to use the GERD quality of life questionnaire. It's been around for over 25 years, and I think part of why we still have many of the questions we have, because there isn't that consistency in following patients. Many people follow patients for a couple of months, but we need to follow our patients for years because we understand this is a dynamic area, and the repairs are not always, they do not always last for as long as we would like them. So really important for us, use those questionnaires because it will help us answer some of these questions for the long term. And we didn't talk about it, but I just wanted to touch on that dissection, that mediastinal dissection that is so important in terms of obtaining the appropriate intra-abdominal esophageal length. Now, that's another controversy, whether there's short esophagus and so forth. Many of us don't believe, but it's the dissection is so critical. And I don't know if anyone had any comments they want to put to that, as well as it's checking the length when it's not on pressure, because sometimes I've seen people, they've got the Penrose around and they're really pulling to convince ourselves that we have the appropriate intra-abdominal length. Any comments on that?
I hate to talk so much, but I totally agree with you. It's got to lay there without any tension at all. We actually don't even use the Penrose anymore, Karen, on these cases. But one other question, and you may answer this down the line because this is, again, one of my pet peeves is, when do you decide to do a bypass or a sleeve in somebody? Are you going to address that, Dr. Sonia?
We're gonna touch on it a little bit, but there's no clear answer for that either, is the consensus of if a patient comes to you with clinical symptoms of reflux, but they take intermittent something, PPI or Tums, and they have control, they have a small hiatal hernia seen on preoperative imaging, what is the right choice for that patient? That is hard to predict. There was a couple retrospective reviews looking to see if they could compare the patients who ultimately underwent conversion from sleeve gastrectomy to Roux-en-Y gastric bypass, and there's a matched cohort of sleeve patients who suffered from reflux afterwards, to say, okay, which patients were more likely to have issues needing conversion because of reflux. And there was really no major correlation. Females lower age were the only two variables on multivariable regression. So I don't know a perfect answer for that question.
I just want to put one thing out there because I think it's interesting. The fact that number one is most of the patients who are submitted to a sleeve gastrectomy and are females that will have a symptom of reflux, you can either fix them or you can do a bypass. Either one is fine. But when it comes to male patients, and I don't know if it's the same thing that you all see, but when it comes to male patients, it's rare for, anecdotally speaking, for us to see the patients complaining of a lot of reflux for some reason. I don't have an explanation for that. But anecdotally, I see patients who are males after a sleeve gastrectomy. It's very rare to have symptomatic reflux. I see more on females. I don't know why, and I don't know if this is just an impression anecdotally or not. I looked in, there is no difference in the literature when I look into that, but it's something that makes me always curious why I don't see the same incidence in males and females.
I mean, we kind of think about the sleeve, right, Karen, as being refluxogenic because you're increasing that, that pressure. But the weight loss may mitigate that. So
Yes.
what do you do in your practice, Karen? Because when I see a hiatal hernia in a BMI greater than 35 patient, I, I go to bypass.
I think that's my choice usually. It really requires having a good conversation. But I would say that in those patients, I also do more of a significant workup to lead that conversation, having objective studies in addition to just, my feelings about GERD. So I find that a lot of people come in and they have the diagnosis, but they've never been tested. They've never been studied. And I think when we're making those decisions, it's good to have objective data.
Yeah, for us here, whenever we do our endoscopies and we find esophagitis, the patients are on PPI on a chronic basis. They are going to have a bypass, unless there is some prohibitive risk or there is an issue with the patient that there is absolutely no way that they want to bypass, and we can opt occasionally for a sleeve, explaining to the patient that that might change into a gastric bypass later on into the process.
Yeah, I definitely agree with that. Recently at a meeting, I was surprised at one of the presentations that talked about Barrett's patients, known Barrett's patients having sleeves. So it's a relative contraindication, but the practice is very diverse.
Please don't, because at least if we have the remnant stomach, we can still do the esophagectomy.
Yes. Yeah, very surprised by that.
Thank you all for those comments. And yeah, in that first survey study, only 34% or 31% considered Barrett's a contraindication to sleeve, which again, surprising, like Dr. Gibbs was saying. So the next section discusses what happens with reflux and hiatal hernias after bariatric surgery. The reported recurrence rate is right around 30%, which was consistent between multiple studies. What's important is when the patients after surgery come back, months, years, whatever later, that we work them up in a similar way that we work up your standard patient with reflux or a hiatal hernia. And so it's a lot of the same testing, EGD, manometry, imaging. pH testing might be less useful in patients who've had a gastric bypass, in which cases impedance testing might be more useful to get to the bottom of their symptoms and measuring the biliary environment. And I'd say even more important in these patients are evaluating their behaviors and their lifestyle, because those same things that cause issues preoperatively are going to be doubly so postoperatively. So making sure they're not smoking, drinking, eating appropriately, that there's no other contributing causes. Looking specifically towards sleeve gastrectomy, and something that we were just talking about too, when these patients present with reflux and a hiatal hernia, even small hiatal hernias, given the nature of the sleeve when it goes into the chest, can be fairly symptomatic for those patients. Looking at rates of what happens after sleeve gastrectomy, these are studied between 1 and 5 years with the various numbers that I'm going to present. But GERD prevalence is anywhere from 25 to 50% after sleeve gastrectomy. Hiatal hernia in a patient who didn't have it repaired was also around 30%. Post-sleeve gastrectomy, Barrett's esophagus report anywhere from 5 to 17%. And in a most recent retrospective review, actually, it was around 11%. So it's still considerably high. This paper published in the Journal of the GI and Hepatology, they looked at the rates of specific Barrett's and other reflux symptoms after sleeve gastrectomy, which was a large meta-analysis, the largest of the kind, including 19 studies, 2,000 patients. The rate of de novo Barrett's esophagus was 5.6%. 48% had reflux symptoms. 33% had erosive esophagitis. 32% hiatal hernia, and 54% were using PPIs. So as we were saying, it is a very refluxogenic procedure that can have, long-term issues. There is some ongoing work and maybe controversy about whether or not routine EGD screening should be done in these patients, given the significant percentage of issues. Here too, practice varies where some will, no routine screening, some only if they're coming back with issues. Some do it routinely at 1 year or 3 years or 5 years, but there is no good consensus regarding, whether or not one that needs to be done or who does it. Looking to with sleeve gastrectomy, what happens when these patients do come back with reflux and hiatal hernias? The obvious, and I would say maybe the gold standard, is converting them from a from a sleeve to a Roux-en-Y gastric bypass. Obviously, this picture is not perfect because they still have the stomach there, but that's not the only option. Some of the more or less common, I would say, if they're presenting with reflux and a hiatal hernia, you could perform a hiatal hernia repair alone. That does take into consideration too, what is their BMI when they're coming back and what does the patient want. Some will perform a hiatal hernia repair with a gastropexy, and there's various descriptions of this. One description is if there's a dilated fundus, using that as a partial wrap. Some have described performing a gastropexy by pexying the stomach back down to pancreatic fascia, or performing like a modified Hill gastropexy when they present with symptoms. And there's even description of using the links post-bariatric surgery, post-sleeve gastrectomy with reflux. So there are options. It was hard to, I couldn't give exact percentages of what's, statistically best, all because that data really wasn't reliably there when looking. But in practice, I would say the gold standard again is converting to a bypass. Looking next to gastric bypass, when these patients also come back with reflux and hernias, the rate of reflux, and it varied widely too, between 5 and 20%. But in those patients who are coming back with reflux, about 50% have hiatal hernias as well. For gastric bypass, I think it's a little different than sleeve gastrectomy, where a small hiatal hernia will usually be asymptomatic. But a large hiatal hernia is more likely to have symptoms. And this is when, half of the entire pouch, the GJ anastomosis is up in the chest. That can present differently in terms of maybe more like obstructive symptoms, dysphagia symptoms. But it's important, again, to work up these patients in the same way, because you don't want to attribute all their problems necessarily to one thing when it could be other imitations, like a GJ stricture, which could present similarly, a GG fistula, internal hernias, or issue at the JJ that backs up all the way. Treatment options here are also fairly varied. If they present with paraesophageal hernia, performing a hiatal hernia repair alone. If they have a GG fistula, taking that down. Some will offer pouch resizing if the pouch is too large. And then some have even described using the remnant stomach as a wrap. This picture isn't perfect because it's a 1 anastomosis gastric bypass, and they use the wrap there. But the idea in the description and publications have been the same, of post-Roux-en-Y gastric bypass using the remnant stomach to perform a wrap of sorts. So again, this was hard to say what's best. Obviously, there's a lot of patient factors going into that, but there are options. I will pause right there to see if there's any comments or discussion before going into 2 quick case examples to end it.
Dr. Podkameni?
Yeah, I do, because I think one of the most important things is the fact that we have to investigate and reiterate to the patient that if they are non-compliant patients, in terms of weight loss, in terms of changing their habits, I think you're going to see some reflux, and then you're going to embark into some kind of shady procedures where there is not enough data to show that there is really good outcome from that. And you're going to start doing things. And I'm not against doing that. I'm just saying that there is not good data to actually show that, for instance, using the remnant stomach as a fundoplication or doing other means of trying to proceed with an anti-reflux procedure on a bypass patient is going to actually improve. So I think the most important thing before even thinking about stepping another going another step in terms of surgery is investigating where the problem is, especially from the fact that we know that reflux is not just a mechanical issue, and it's also a metabolic issue related to obesity by leptin, by ghrelin, by GLP-1, etc. So there is that needs to be addressed before we move on into doing more surgeries. And especially when it comes to a bypass patients, that we are not expecting them to present with reflux symptoms anymore, unless we're talking about biliary symptoms, and then the investigation and the procedure is going to be totally different than anti-reflux procedure.
Dr. Aguayo had a great question. Anyone that has experience on this call using the remnant as a fundoplication, do you see GG fistulas created as a basis of that procedure? Has anyone ever seen a patient, I guess, in their practice that has had the remnant as a fundoplication?
Yeah, I have seen a few just in town, and I had to revise some of them due to hiatal hernia recurrence. And uh, one of the patients, actually, I had to move the JJ down because the JJ was too close to the gastrocnemius edge, leading to biliary reflux, actually. So that's why I'm saying we have to be careful when we come up with very brilliant procedures that this is going to fix everything. It's just to be very careful in addressing that. That's all.
Absolutely. I have seen one patient who had this, and it really, they had obstructive symptoms just because the wrap was too tight.
Has anyone seen a lynx placed on top of this? Because that's something that
I'm
people
sure it
do,
has been.
which I don't understand. I've also seen a lynx placed on a sleeve, and you're supposed to not have anything to anchor it on the greater curvature side, right? If you do the sleeve correctly. So it's shocking to me, but this happens.
Yeah, there's also the omental flap that's being done as well. We're very creative. So, and I think we need to be, because this is just such a dynamic area that we understand that there isn't a perfect fix, but I absolutely agree that it really requires that if we're going to do any additional operation, we really have to study those patients and understand physiologically as well as anatomically what's happening with them.
Dr. Rivas and Dr. Cho are also on this call, also two experts in this topic. Would you like to give us your 2 cents? I don't know, Dr. Rivas.
Dr.
Yeah, sure, I can.
Rivas?
Yeah, I mean, we published on, Hill gastroplasty after both sleeve gastrectomy and gastric bypass. It actually came about years ago. I mean, this is 2013, 2014. I had a patient after gastric bypass with objectively demonstrated reflux disease, et cetera. And I think links had just come through the clinical trial, submitted, denied, appeal, denied, and asked them, so what do you want to do for this patient? And they said, well, we're an insurance company. We can tell you what you can't do, but we can't tell you what you should do. I said, fine. So how about a Hill gastroplasty? And I said, what's that? I said, it involves sutures. And they said, does it involve an implant? I said, no. And they said, okay. So that is the birth of our experience with Hill gastroplasty post-bariatric. And luckily, Rafa, who, learned from Lucius Hill, and Lee Swanstrom, my emeritus partner, who also learned from Lucius Hill, kind of shared with me that. And so we have a series now of patients. And obviously, it's a little bit apples and oranges in terms of the overall patient population, because these are not obviously standard native anatomy type individuals. They have narrow sleeves, wide sleeves, large pouches, small pouches, and such that we're working with. But ideally, kind of like what I think had been mentioned before, if there's a little bit of generosity of the upper area, a little bit of retained fundus, or even just dilation, if you have 3 centimeters width, 3 or 4 centimeters width to work with, Hill gastroplasty is certainly doable. And essentially just it's essentially a cardioplasty, using those that section of the pouch, immediately adjacent to the esophagogastric junction. For those who've followed Lucius Hill's original papers, but it works well. We're able to usually get a pretty nice anti-reflux valve constructed. You can retroflex in a pouch if it's generous and see it. And the post-operative objective testing, improves, sometimes completely, corrects their regurgitation as well. There's debate as to whether it's whether it's a dysphagogenic or safe in patients with poor motility. We've used it in both folks with IEM as well as normal motility and had success there. Yeah, that's kind of been our experience over the last 11 years.
Dr. Rivas, just to follow up on that, are you using the EndoFlip with these procedures?
Usually not to calibrate. Usually where I use EndoFlip most commonly is going to be kind of as a kind of a tie break when we've got discordant, studies with motility and upper GI or patients with, symptoms, or patients that can't tolerate motility testing. That's where I usually deal with it. In terms, I do calibrate over a 48 French bougie, which is, kind of old school.
Yep.
The original description had 4 sutures. I had a lot of dysphagia and some angulation of the Hill gastroplasty using that approach. So I have dropped it back to 3. And it seems to be a bit of a happy medium in this, patient subset. Yeah, I love EndoFlip, but I don't routinely use it in this particular circumstance for calibration. It's usually patients are suffering and like, look, whatever you can do to make it as robust as you possibly can. But yeah, obviously, we're shooting for, a DI 3 to 6, but yeah, that's our methodology right now is with really the 48 French bougie calibrator.
Excellent. Dr. Sohim?
Dr. Gibbs, I just wanted to jump in and say we are routinely using EndoFlip to guide our closures, and I've been really surprised at how crural closure alone actually is enough, actually.
So I,
But
I
this
was going
on
to ask you if is crural closure enough?
So I've actually said this on this call and got a lot of shade for it, but I'm going to say this again. No wrap is better than a slipped wrap. So I actually, and it depends on what you're dealing with, right? If your primary issue is reflux, then that's a whole different game. But if you're dealing with a para, for example, we actually will do just EndoFlip guided closure and a gastropexy in those patients. I know it's heresy, but 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 hear me out.
It's not heresy. I think what we need to do is follow those patients and study them so then we can understand, is the wrap enough? Because as you can see, we're doing a lot of different things, but we lack some objective data to help guide us as we're moving forward in that. So great points made. Thank you.
Perfect. Yeah, thank you, everyone. That was the end of the presentation, actually. And I don't know, in the interest of time, stopping now or going over, I have 2 case examples that might lead to more than a couple minutes of discussion, which is left.
Why don't you pick your favorite one, and then we can see how we go.
Sure. All right. Well, I'll start with the first one, I suppose. It's a case of a 45-year-old woman with a BMI of 50 and a pre-op GERD symptoms who undergoes a sleeve gastrectomy. 3 years later, has significant reflux, EGD with some esophagitis and a moderate-sized paraesophageal hernia. At the time, her BMI is 26. And I only bring that up to pose the question of, in a patient who comes back after a sleeve with reflux and a paraesophageal hernia, this one, maybe you lost an unrealistic amount of weight from 50 to 26, but is the right answer converting to a Roux-en-Y gastric bypass in a patient like that, or performing the paraesophageal hernia repair alone? I will give the spoiler of I couldn't find a great answer to that question of whether or not one really confers a major benefit. So I think that more or less comes down to surgeon experience. And in my limited experience, I've seen both done and both be successful.
Dr. Ewing, Dr. Ogoyo, as the fellows on this call, I would like to toss this to you. What are you going to do in 3 months from now when this patient shows up at your door?
Well, now it sounds like the gastropexy is a good alternative. With hiatal hernia repair. You can also make you can do a bypass, but do a very sorry, I'm at the airport. You can do a bypass, obviously bypassing very little bowel.
Dr. Ewing, what do you think? You're on mute.
I'm with Ryan. I've seen both, both done in a similar situation here. Obviously, it's complicated by the fact that the patient has a normal BMI, and it's only grade A esophagitis. If it was grade D esophagitis or C, I may have a little bit different answer. But I still think I would tend towards room-wide gastric bypass with a shorter limb, less so for weight loss and more just for gastric diversion. Um, it's just being the most definitive repair for this patient. But I would probably have a discussion with them about, risk benefits and, lifestyle changes and dietary changes and kind of pose both options probably to the patient and work towards a discussion, but lean a little bit more towards gastric bypass. Obviously, I would make sure they've exhausted all their, medical management and stuff, but I would assume they'd have some amount of symptoms related to the hernia, not just their GERD and esophagitis.
Can I say something? Dr. Sohim will answer what he found in regards of that case. But I think one important point is the fact that doing a gastric bypass on someone who already lost a significant amount of weight doesn't mean I keep on losing weight. So don't hesitate to do a correct Roux-en-Y gastric bypass on those patients because it's very likely that they are not going to lose more weight than tipping staying at a BMI around 25, 26, or 24, around that area. So don't hesitate on that because that's a misconception.
Absolutely. Great point.
Could you also make the pouch a little bit bigger, or do you still make the 30 cc pouch?
I would make the bypass exactly how I would make for
Okay.
any other patient.
You don't want to increase the risk of marginal ulceration there. So yeah, keep
Right.
the pouch small.
Yeah, I put in the chat the reference of our paper too. We found that in patients, exactly as you said, David, that the patients where you were revising basically either for gastroparesis or paras that were normal weight, they actually did not lose much weight because they were actually better after the surgery than they were before. So if anything, they tended to gain weight, which it can be an issue. So totally agree with you. And thank you for making the point, Dr. Gibbs. Don't make a big pouch because you're going to get a marginal ulcer if that happens.
Excellent. Thank you, everyone, so much. Special thank you to Dr. Soham, Dr. Gibbs, and everyone that was here. It was a really great interactive last grand rounds of this year. Dr. Soham, if you wouldn't mind unsharing for a moment so we can get our screenshot for our Twitter picture. And